The views, opinions, and advice in this podcast are not necessarily those of our employers. Medical topics are discussed largely using best EMS protocols. Discussions here should not replace your own services, policies, and procedures. Hey guys, today we're going to be discussing some issues that Dr. Northeim and Dr. Bertrand have seen as common issues among EMS from the perspective of medical direction.
Okay, so one of the other pearls, or one of the other topics for today, we're talking about IV antibiotics pre-hospital. I know there's some agencies that have been doing it for a couple years. They've been doing blood cultures in the field, and I have to admit, thanks to our EMS partners down in Florida, Dr. Handevi and their group, they listened to one of their podcasts, and I was enlightened to hear that there's actually blood culture vials that have the technology to sequester antibiotics, so the antibiotics will not affect the culture results. And for me, prior to hearing that podcast, I was completely against IV antibiotics in the field, mostly because I didn't want our crews to have to draw sterile blood cultures, and I was really worried about contamination rates and potentially patients getting cultures back that were positive or 1 of 2, and then having to stay in the hospital and longer hospital stays, longer antibiotics time. But when I heard their lecture and heard how well they were doing with it, and knowing that these severely septic or septic shock patients, every hour that goes by without antibiotics is about a 35% difference in their chance of survivability. I thought that was pretty powerful. And when we started asking hospitals in our area kind of the average time of door to antibiotic rates, they were anywhere from an hour and a half to 4 hours. And so we wanted to, as a group with Best EMS, we really wanted to focus on the sickest of the sick patients. And we got a tremendous amount of pushback. Everyone, all the hospitals are obviously very concerned with falling out with CMS and stuff like that. And we found out through our abstractors that that's not the case. No different than going to an urgent care, a care now, a freestanding ER, and someone got Rocephin, and we pick them up and we take them to the hospital. That's the same case, right? This does not affect the hospital's CMS guidelines for antibiotics. And so we have started to do it with many agencies across the system. In fact, our RAC, on the RAC level, they've actually formed an EMS sepsis committee now. And so we're still following our RAC's sepsis criteria. We're still hitting fluids. Our goal in the field is 100 mLs per minute transported, and obviously with a goal of 30 cc's per kg ideal body weight. But what we've added is latch criteria, and Skipper, you want to talk about that?
Yeah. So on our protocols, you need to meet at least 2 of the latch criteria, and this is for our patients only over age 18. Okay, and the latch criteria would be a lactate over 2.0 for those of our agencies who can perform lactates in the field, altered mental status, a temperature of greater than 100.4, less than 96.8, a Capno reading of less than 20, or is it 25, and also if they have any evidence of hypotension. And so when you look at the amazing strides we've made in the hospital setting with regards to giving antibiotics earlier in sepsis, you can remember 10, 15 years ago, if you had a septic patient come in, it may be 6 or 8 hours before they actually got antibiotics. Okay. It was late. A lot of times they wanted to make sure all of the urinalysis was back, and the strides we've made in the hospital, there's no way that would not transfer to actually seeing patients in the field and getting antibiotics started early. If myself or any of my family members ever meet this criteria, I would want them to get antibiotics as soon as possible. And now that we know that we have these special blood culture mediums that can sequester the antibiotic and it will not interfere with the cultures, then there just seems to be no reason on those patients who are clearly septic or at a high risk for sepsis why we would not start antibiotics early. And like Dr. Northeim said, if you look at once patients hit the door, it may be anywhere from 1 to 4 hours before they get antibiotics in the ER. It's certainly rare that it's going to be within 1 hour, okay? But then if you put on top of that, what time did they call EMS? And especially in an area like this where transport times may be 30 minutes, well, that's an even 30 more minutes added. And like Jeff said earlier, a lot of times these patients if they're at this stage, they're way behind the 8 ball. They should have called hours ago.
Yeah. So, right, and this is not heart rate of 92 and respiratory rate of 22, right? I mean, this is hypotensive plus altered. This is hypotensive plus capno less than 25. This is febrile plus hypotensive. This is lactate greater than 2 plus altered, right? So they have to meet 2. And so we kind of put it together as latch. I know Florida, they had a different criteria, but thanks for their leadership down there. We kind of piggybacked on that. It's been a big push. It's been a big collaborative effort across our RAC and trying to collaborate with the hospitals as well. But when I ask some of the sepsis leadership at the hospitals, would you be prouder if your antibiotic time was 30 minutes sooner, right? Their door to antibiotic time. Absolutely. But, there was a little pushback initially because we were worried about the blood culture before antibiotics and stuff. I would say this is the same patient population with the same disease process, right? And we're essentially, even if you have a short transport time agency that's giving it, 5 minutes prior to hitting the door and starting it, right? And then the hospital finishes it up, it is still a lot earlier than what they're getting, right?
Yes.
And so what we're going to do is we're going to look at mortality differences between, EMS agencies using the antibiotics versus not, and we're going to collaborate with our sepsis leaders. And, at the end of the year, if we change mortality, great, we'll keep it going, right? Which I think is going to happen. If we don't, then, it's something that we could put on the table and say, hey, we don't want to ever make it where we have to do stuff that's not impacting patient care. But what we truly believe across our system of 8 docs and several other of our infectious disease physicians and other sepsis leaders, that this will make a difference.
So we've been going through training on Rocephin. That's the antibiotic we're going to be carrying. I'm going to ask you guys a couple of questions that some of our medics have been asking. And the first one, I guess a couple of other agencies somewhere that carry antibiotics, I can't remember where, they have a set of vital sign parameters they have to be above before they give antibiotics because of a concern of maybe some hypotension giving it. Are you guys aware of that? Does Rocephin cause that?
So sometimes with E. coli infections, you can actually drop your blood pressure, but routinely in the ER, if you have a septic shock patient, we're going to still do it.
They're obviously already getting treatment for hypotension typically.
Right. We're still going to do fluids. We're still going to focus on that. We should still focus on stabilizing the blood pressure, right? Much like prior to intubation, we want to fill the tank and we want to resuscitate the patient. Obviously, resuscitation's first, getting their pressure up. But, we do have medicines that combat that. Obviously, if they drop the pressure in the ER, we're going to start, push dose pressors or norepi or epi or whatever we need. So we have the similar tools here, and so do all the agencies carrying it. So I would not let that limit you, but I wouldn't be surprised if it does drop the blood pressure a little bit, especially for some of the E. coli infections. You've seen that.
So first IV is obviously your fluids, your pressors. Your second IV is where you're given that antibiotic.
Right.
Yes.
The other question was, is there a chance that we get the septic patient, we start resuscitating, we give the antibiotic, and then somehow their lab values or their findings make it so that the hospital is not as aggressive in some way. You know what I mean? Like we get there and they're like, hey, their lactate's 1.5, they're big deal.
So I think no matter what, you have to tell a story. And we've been doing this for years with a patient who's tachy at 120, right? And you guys give 2 liters, well, their heart rate's now 88, right? So it's really important that during that patient handoff, you tell him, hey, this guy's pressure was 70. We gave him a bump of push dose. This guy's heart rate was 130. This guy was febrile, right? And we've now given IV Tylenol and 2 liters of fluid. It's important to tell us that story because that patient has already met service criteria or severe sepsis criteria in that case. The initial lactate was this, and we get a lactate and it was normal. That's all important information. But we still have to treat the patient and do the best care. Now, the other question about is, I know Florida added gentamicin, but I think they couldn't get it. There was some back order. Zocin's relatively expensive. I think cefepim's in the $200 a dose range. So we understand that some of these patients, especially nursing home patient with maybe like an ESBL or a Pseudomonas infection, we're not going to be covering them effectively. We can always add antibiotics in the ER, but I think it's hard to carry a broad spectrum. I think that we've kept this as an addendum protocol. So, we could make changes. We could add gent in. We could, go to a more expensive antibiotic. I think we're just trying to get it rolling, trying to see how we do. I think a majority of patients is going to help, but they can finally kind of tune the antibiotics when they get there as well, add something to it.
Yeah, and the other question that we'll get frequently also is if they have a allergy to penicillins, right? We get this frequently. And we're given Rocephin, which is cephalosporin. And there is a small chance of cross-reactivity on that allergy, but I don't know that I've ever actually had anyone cross-react. I don't know if you have in my whole career. As long now if they have an allergy to cephalosporins, certainly they're not going to get ceftriaxone or Rocephin. But I would not be afraid. I would not let it stop me from giving the patient an antibiotic, even if they have a history of hives or severe reaction to penicillin. Just that I wish that we could get away from that worry about the cross-reactivity. And it's funny, even when we talk to pharmacists about it, because it pops up on Epic, on our hospital system, anytime you go to give it, they have penicillin allergy. The pharmacists will tell you not to worry about it. And I asked them, I remember when we went to Epic, well, can we just get it taken out of here? And they're like, well, no, we can't really. So just don't let that stop you from administering or delaying the antibiotics. It's not that big of a concern for us.
There is a
liability thing.
Yeah, and there is actually a new calculation. I can't recall the name of it for penicillin. So if it's been a certain amount of years since your penicillin allergic reaction, if your reaction was this, and there's several criteria that you could actually go back and give penicillin, which is good because if something happened to you at 2 years old and now you're 40. And maybe you have an allergy to like a quinolone or something. It's kind of nice to have, the ability to give that penicillin, especially if you don't want to spend the night in the hospital and penicillin's your only option. So, we're going with it. We're going to try it. We're going to see how things go. And we're going to ultimately track our difference in patients' mortality and see how it goes. But
awesome. I'm excited to use it. Last one?
All right, so last thing we wanted to kind of talk about was a little bit about capnography, and we all know kind of capnography numbers, right? 35, 45. I think the important piece is try to get more educated on the waveform. I think like Skipper said earlier, it's kind of hard to hear lung sounds. We may not always hear the wheeze, right? The expiratory wheeze. Look for shark finning, right? Look for your coroid clef. I think the other important part is if you're doing a CPR, you've got to have capnography on this patient, right? In addition, if you're using a supraglottic device, whatever you're using, we use iGel, but if you're using a King, so whatever you're using, you have to use Capno. Capno is the only way to ensure that that supraglottic device is actually seated correctly, sized correctly, and more importantly, you are taking a large foreign body to an airway that is open and potentially occluding that airway. And without capnography, you're not going to know. I had a case a few weeks ago. I was writing out at an agency that got there as a CPR. We stuck the iGel down. About 5 minutes in, we didn't have Capno. I said, hey, get some Capno. We couldn't get a good waveform. And so I pulled it. We took a look, and the patient had a giant piece of steak in their airway. If you're an agency that leaves a supraglottic throughout the entire code, that's going to be a problem. We have an airway occlusion that we could have done something about, right? And you're not going to know. You're not taking that early look. With capnography, you know that the patient is actually getting, oxygen CO2 exchange. So that's a really important piece. And this patient was not in a dining hall. It wasn't your typical nursing home dining hall. Could they have choked? This person had, probably eaten it and then, gone to bed. So it really opened my eyes to we've got to make sure. And even if you're bagging somebody, right? I mean, to know what their capno is doing is really important. So anyway, that's the main clinical thing for that. I hear a lot of, knowing the numbers of capno, but not necessarily understanding the waveform. And I think seeing a shark fin, I had a patient the other day that was on the vent that got super tight, airway pressure started going up, and I looked at the monitor and there was shark finning. I knew, hey, we need to, go down the albuterol route, and we need to start, hitting this patient with some bronchospasm meds and treat them effectively that way. But it's still kind of hard to hear. They were kind of tight, right? It's a very helpful waveform to watch.
Yeah, and I would encourage our crews to, when you dropping off a patient in the hospital and transferring them to the ER staff, to encourage them to put the patient on Capno, because it happens in our department also. Nurses just don't put the patient on Capno, and then pulse ox starts dropping, and then you're behind the 8 ball at that point, right?
Yeah, or they go to CT, right? Yeah. Go to CT. I mean, it's important to have Capno to watch it real time and make sure your tube's good.
Yeah, so encourage the nurses to put the patient on Capno before you leave, so that we can be aware of what's going on with it.
So we've moved away from intubating cardiac arrest pretty much until we've at least been doing CPR for 10 minutes. That's our current practice. So if I throw an iGel in, And just kind of a scenario. I throw an eye gel in, and I don't have any reason to suspect airway occlusion because I've done that before and like started to go with an eye gel. Oh, there's food in there. Let me clear that out, and then just end up intubating. But you throw an eye gel down, you don't have end tidal, can't get end tidal, reposition, still can't get end tidal. Are you going to go intubate, or are you going to put a new eye gel in?
I'm gonna take a look.
Okay, yeah. So every time we're not worrying about replacing this device. We're going to we're going to intubate. We're going to actually get a definitive airway. Okay.
Correct. And I think going down this route is, I'm pretty sure everyone knows this, but if you get an ET tube in place and you can't get capno waveform, right? We always pull the tube.
Yes.
Right? I mean, obviously take a look, but no matter if, Dr. Bertrand and Jeff and I all saw on the camera that it went in, right? Or, hey, we've been having problems with this monitor, or it's probably an occluded line. That's never going to stand up medical legally. So always better to pull it and use a supraglottic or manually bag with an oral airway or nasal, whatever you want to do, but don't keep that in place, right? I mean, repurge it, retry it, maybe try a new line, but in the meantime, we need to pull it and make sure that we're actually ventilating the patient because that would be the safest thing.
Yes.
What if you think the device is the wrong size? Like what if you're like, hey, I threw a 3 in this person, maybe it needs to be a 4. You're going to see some end tidal even if your eye gel's not exactly the right size, right?
Yeah, no, you will. And you're probably going to get some sort of air leak, right? So I don't mind sizing up and seeing how it is, especially if the low suspicion of foreign body. But, you get to a kiddo and they've got, who knows, Lego in their mouth and we're coding this patient and maybe it's an agency that decides to leave the eye gel on the whole time. I mean, you're not going to know about the foreign body unless you have capnography. So we really stress CPR, absolutely. Any advanced airway, whether it's eye gel for us or ET tube, needs to have that. And when you upload your vitals, that should be a direct upload from your monitor to your chart. So if you don't have capnography on your chart, that means you didn't have it going. And so I would also say too, after you intubate, I go right to inline. I mean, I have it ready. I don't usually use the color one anymore. I think that if you're using a bougie, you can always put your inline on the top. You can put it over. Your first breath is on the monitor. If you're using a glide scope and you have a stylet, put your inline right away, get your breaths up there. And that's something respiratory therapy is really not used to yet. I mean, we kind of have differing practices, differing docs and differing respiratory therapists, but that's what I do routinely. I mean, I'm going right to that. I said, hey, you have some inline capno ready. I'm going right to that because what happens majority of the time, you put the color, put it on and then you pull it off and the top of the tube comes out and, it's just, you're going to keep the inline on. Just put the inline and use it. That's kind of my practice, and I know a lot of our medics do that as well.
I agree. And then the inline's on because also they might not put the inline on for, another 5 minutes or so, as long as because they're so comfortable with the color change. Right. So just get it on. Yeah.
And so just kind of an interesting little, like kind of the other side of I don't have any capno. I had a cardiac arrest, I think last year or year before that, where there was an air leak in the eye gel. And we had just gotten eye gels, and I wasn't super familiar with troubleshooting, but I kind of repositioned it, and I'm like, okay, what is going on? The end tidal was just consistently 80. I couldn't get it down. I increased the respiratory rate. I couldn't get it down. Like, I think we got ROSC at this point. So, but I was, okay, breathing 20 times a minute, still 80. Breathing 25 times a minute, it's still 80. Like, it just would not. And so I think the air leak was basically not allowing me to fully give a breath. Like, I wasn't actually ventilating this person. So after 5-10 minutes of trying to troubleshoot this, I'm like, I have to intubate this person because their end tidal is just not coming down. And so pulled the tube, intubated, end tidal's 45. I mean, like, I was able to bag them down within about 60 seconds. So I'm not sure exactly. Basically, my point is an air leak doesn't always look like no capno. Sometimes it's just like I'm not actually ventilating this person all the way because when I'm squeezing the bag, some of that air is coming back out. So it was. I've never seen it other than that one time, but it was definitely new to me. So
I've not seen that. No, sir.
Well, we hope you enjoyed today and these podcasts. Just trying to do some clinical pearls, and we'll try to think of some more here for the next few months. But thanks for joining us.
Yeah, if you have anything you would like to see particularly for us to talk about, give us a shout.
Yeah. What email address would we use for
yours?
Yeah, mine. Okay. All right. So I'll put my email address in the notes or in the video description, podcast link, whatever. And thank you guys for joining us. See you guys next time.
Thank y'all.
You need to get it to pop up, you can say.
He will.
Send your email to the link below.
Yeah. Just like
Like and subscribe.
Yeah. This has been an episode of the PCHD EMS Podcast. Thank you for joining us.